Okay, so we can start the session. Now, the very first question is about a 32-year-old female who had undergone total thyroidectomy for papillary carcinoma. On the second post-operative day, she developed perioral numbness and carpopedal spasm, and on ECG there was prolongation of QT interval, and serum calcium came out to be 6.8 milligram per deciliter. Now this is a very classical question and it has been repeated many number of times. So if we just write the keywords first, whatever has been given in the question, like post-operative case, and what surgery has been done? Total thyroidectomy, right, for papillary carcinoma thyroid. Now what had happened? Second post-operative day. Now what are the complaints the lady is having? Perioral numbness, means numbness around the mouth. Then secondly, carpopedal spasm. Carpo means hand, pedal means foot. So there is a spasm of the small muscles of the hand and foot. And then on ECG, there is prolongation of QT interval. And lastly, look at the serum calcium values. It is 6.8 mg per deciliter. Now the normal value for serum calcium is around 9 to 11. So what we can see, the calcium level is falling down, right? The lady is having irritation of the neuromuscular unit, and that is resulting in carpopedal spasm. Prolongation of QT interval, classical finding for hypocalcemia. Then all this is happening because the thyroid gland was surgically removed, and along with that there is inadvertent removal of parathyroid as well. So this is a classical case of parathyroid removal. It can be accidental devascularization or accidental removal of the parathyroid, right? So when the parathyroid is gone, it means there is no parathormone and there will be resultant fall in serum calcium. And that what is the picture of classical picture of hypocalcemia in the given question, right? So this is how you have to reach up to the diagnosis, and in this particular question there are plenty of hints which suggest the diagnosis of hypocalcemia. So here the option or the answer is accidental devascularization of parathyroid, or there can be accidental removal of parathyroid leading to hypocalcemia. So this is one very favorite question. In some or other way it has been always asked, so please don't do any mistake in this, right? Hypocalcemia, very important from exam point of view. Then next question was about a 28-year-old woman. He is having a solitary thyroid nodule. Then ultrasound reveals hypoechoic lesion with microcalcification. Then FNAC is showing nuclear grooves and intranuclear inclusions. Now what is the diagnosis? Now remember, let us firstly take the keywords given in the question. The very first keyword is the age of the lady, right? So 28-year-old female, she is having a solitary thyroid nodule. Now ultrasound is showing hypoechoic lesion with microcalcifications. Now this is what? This is actually Samoma bodies. Clear? So this is the classical presentation of Samoma bodies. Now what we see in fine needle aspiration cytology, we are seeing nuclear grooves and classically intranuclear inclusions, and these intranuclear inclusions are suggestive of orphan Neide nuclei. Clear? So I think most of you must be knowing that Samoma bodies or the orphan Neide nuclei, they are classical for which variety? Papillary carcinoma. So in a young lady, overall, I think all of you must be knowing that this is the most common papillary tumor. Clear? This is the most common, especially seen in females, and we see Samoma bodies, orphan Neide nuclei, which, and then nuclear grooves are very important pathological feature of papillary carcinoma of thyroid. So papillary carcinoma of thyroid is very important from exam point of view, and every year, every session we see at least a couple of questions from this topic, papillary carcinoma of thyroid. The next question, a 48-year-old woman undergoes modified radical mastectomy, and after the surgery she notices inability to push against a wall, and there is prominence of the medial border of scapula. Now which nerve is injured here? So let us write the keywords first. It's a case of modified radical mastectomy, right? So done for carcinoma breast, and post-operatively what happened? She is unable to push against a wall, and the moment she tries to do so, there is prominence of medial border of scapula. Now what is this? This is the classical winging of scapula. And now the moment you come to know about winging of scapula, you can easily answer that this is paralysis of which muscle? Serratus anterior muscle, and the nerve supply of serratus anterior is what? So there is paralysis of long thoracic nerve of bell, right? So see, such a easy concept, such a easy question, and it has been repeated many number of times. Every year we see a question based on this, but they have integrated it in such a manner that you have to derive the answer, right? In older times it was like winging of scapula is seen because of paralysis of which nerve, but nowadays they just twist the words. So you have to be very specific for identifying the condition first, and once you identify this, then you can quickly mark your answer, right? So this is now long thoracic nerve of bell injury, and the patient is unable to do pushing or punching action because that is the action of serratus anterior. Then moving forward, a 55-year-old woman presents with hard breast lump. Now this was subjected to biopsy which showed signet ring cells. Later on she developed tumor in the opposite breast as well. Now most likely subtype. So here what are the keywords given to us? The very first, microscopy showing signet ring cell, and importantly involvement of opposite side as well. So what we'll call it, means this is a bilateral tumor. It is involving both the sides, and the lobular one is the subtype which is bilateral, right? So invasive lobular carcinoma is the one which is bilateral. So this bilateral word is very important here, and this gives us the hint that the subtype which is under discussion is the lobular variety, right? So signet ring cells and bilateral means right and then left as well. So many times there is another way of putting this question, like if the in which of the following variety we need to evaluate the other breast as well. So the answer has to be lobular carcinoma, right? Because it can involve both the breast. Then a 19-year-old student develops vague periumbilical pain followed by nausea, and then 12 hours later the pain shifts to the right iliac fossa, and then the tenderness was noticed at the McBurney's point. Now, why there is migration of this pain? Now, I think the clinical condition most of you must have understood that it is a case of acute appendicitis. So here, if we write the keywords, given to us in the question, initially the pain was periumbilical, means around the umbilicals, but later on, after say 12 hours, it shifted to right iliac fossa. So now what is the cause of this? Now what happens, this is absolutely a case of acute appendicitis. Now initially what happens, there is visceral pain. Visceral pain is poorly localized, but when there is inflammation of the parietal peritoneum, the pain becomes more easily localized. So it means the visceral to parietal peritoneal involvement, because visceral pain is poorly localized. But as soon as there is involvement of the parietal peritoneal layer, parietal pain is well localized. Clear? So what is happening? The pain is going from the visceral to the parietal peritoneal layer. So that's the reason why the shifting of or the migration of the pain is happening. So that's just a basic concept. Now, a patient presents 5 days after the onset of appendicitis, and then there is a tender right iliac fossa lump. Now, what should be the management? Now, here obviously the case was of acute appendicitis, but now what has happened after a gap of or after 5 days? Now what is happening? There is formation of a tender right iliac fossa lump. Clear? So there is formation of a lump. This is also known as phlegmon or appendicular mass, right? So now what to do in such a case? In such a case, never operate, right? So in such a case, never operate and treat the patient conservatively. Clear? So treat the patient conservatively. And what is the name of that regime? This is Ochsner-Sharon regime. So this is very important to understand, that after few days of acute appendicitis, the body will try to localize the infection. There will be movement of the omentum, and they will just try to localize the infection. So in such a case, we need to wait for some time. So better go with Ochsner-Sharon regime, where we will give antibiotics, IV fluids, and interval appendectomy can be done later. So at this moment of time, in the state of phlegmon, don't do any surgical procedure. Better go for conservative management, let the inflammation and the infection subside first. So that's very important, and this question has been asked many number of times. Ochsner Sherin regime. Okay. Okay. Okay, Lokesh, some noise is coming. Chalo. Anyway, next question. A 60-year-old man who underwent laparotomy 2 years ago presents with colicky pain, vomiting, abdominal distension, and constipation. Now, X-ray showing multiple air fluid levels. Right? So, let us write the keywords first, and I think most of you must have understood the condition, or you must have understood the reason for this. So, let us take the keywords first, and I think then you will never do any mistake in this kind of question. So, the patient is a known case of laparotomy which was done 2 years back. Clear? So, it means the abdomen was opened, some surgery was done, and then the abdomen was repaired. So, operative intervention over abdomen. Now, what is the clinical presentation right now? Colicky pain. Colicky pain means the pain will come and it will go. So, off and on. It's not constant, right? So, it is off and on, colicky pain. Then there is vomiting, distension. Distension means there is some obstruction. That's why there is distension. And just because of this obstruction, there can be constipation as well, altered bowel habits. So, constipation and distension because of obstruction. And the classical picture of obstruction on X-ray is air fluid levels, right? Air fluid level. So, obstruction is clear because of distension, because of constipation, and also the X-ray is showing multiple air fluid levels. So, we have understood one thing, that after a surgery, laparotomy, 2 years later, the patient is having obstruction of small bowel, you can say. So, if we write it like this, laparotomy, after 2 years, there is obstruction of gut. Now, what can be the reason why there is obstruction after 2 years? So, in surgical practice, the most common cause is post-operative adhesions, right? So, if there is any mention of surgery done few years back, then these are actually post-operative adhesions, right? So, these are post-operative adhesions. It means the GIT is not involved in any pathology. It is just because of those adhesions. It is either kinked or bent or compressed like that. So, that is resulting in obstruction, right? So, whenever you find any mention of surgery, after few hours of surgery, close your eyes, think of post-operative adhesions. Although other conditions can also present as bowel obstruction, right? Volvulus is okay, intussusception is okay, but this is a classical case of post-laparotomy, right? So, already the surgery has been done, so we should go for post-operative adhesions, right? Very important, and this will result in obstruction, right? So, I think now you will never forget this particular concept. Chalo, next question. An elderly patient presents with progressive constipation, abdominal distension, and weight loss. X-ray showing dilated colon, and collapsed rectum. Most likely diagnosis. Now this is a very beautiful question, and I think some of the hint we can take from the previous question. Pathak, Navya, yes, Navya, you are absolutely right. In the previous question it is, yes, for this, yes, Navya, you are absolutely right. Now see, let us take the keywords here, and this will make your concept much more clearer. You will never forget. The very first word which has been given in the question is elderly. The moment you find the word elderly, always think of, okay, the question might go towards some malignancy. The very first thing, right? So elderly. Then progressive constipation. Now progressive means it is increasing day by day. So progressive, right? So progressive means it is increasing day by day. Then abdominal distension. Now these 2 points we already discussed in the previous question, that constipation, distension, it might hint towards obstruction. So maybe there is some, this question is about some gut obstruction, maybe, right? Now one more classical word is weight loss. So elderly, weight loss, more likelihood of malignancy. Clear? Elderly, weight loss, more likelihood of malignancy. Now if we look at further clues, dilated colon and collapsed rectum. So it means the picture is something like this, So it means the tumor is somewhere here. So it is causing dilatation proximally and collapse distally. And we know that most common site of large bowel carcinoma is colorectal carcinoma. So see how such a beautiful description of carcinoma colon. Clear? So this is carcinoma colon, especially in the left side, where we see that it's a annular lesion which can lead to narrowing of the lumen, and we can see apple core sign on barium studies, right? So this is very beautiful formation of a question related to carcinoma colon. Elderly, weight loss, think of malignancy. Now malignancy of which region? Obviously of the colorectal region, because there is constipation, distension, dilated colon and collapsed rectum, right? So this is how you will reach up to your diagnosis of malignancy or carcinoma of colon. Very good, Navya. Next question. A chronic NSAID user, non-steroidal anti-inflammatory drug user, like aspirin, like sudden development of severe epigastric pain, there is board-like rigidity, and the erect chest X-ray shows free gas under diaphragm. Now this is a hot favorite. Every year, every session, every exam, there has to be a question based on air under diaphragm. So here I think most of you must have reached up to the answer. Let me take the keywords so that your knowledge becomes much more consolidated. Chronic NSAID user. NSAID means painkiller. So the patient is taking painkiller for a long period of time, maybe aspirin or diclofenac, anyone. Now, what is the clinical presentation now? Sudden, severe epigastric pain, right? And per abdominal examination, how the abdomen is feeling? Board-like rigid, just like a wooden plank, right? So it's very hard. And the chest X-ray erect view is showing gas under diaphragm. So the gas is collecting under the diaphragm or the dome of the diaphragm, and this gas has been released from GIT, especially if there is perforation, right? So perforated duodenal ulcer is the commonest condition which presents as gas under diaphragm, and this gas under diaphragm is also known as pneumoperitoneum. So please be perfect with this concept. Every year we have a question from this particular scenario. It may be gas under diaphragm or perforated duodenal ulcer or perforated viscous. So the broad topic remains the same. So please be perfect with this. There is no scope of error in such easy scoring questions. The next question, a 45-year-old obese lady develops severe epigastric pain, and that is radiating to the back, and that is especially after a fatty meal. Lipase is markedly elevated. Now, most likely etiology. So they aren't asking you the diagnosis, they are asking you the etiology of that diagnosis. So firstly we have to reach up to the diagnosis, and then we will go up to the etiology for that clinical diagnosis. So here let us write the keywords first. 45 years, fat female, right? So instead of woman I am writing female, instead of obese I am writing fat, and here this is 45. So what you can see, F, F, F. So a fat female in 40s. Okay, now moving forward, clinical presentation, epigastric pain radiating back, right? So radiating backwards, and then investigation shows increased serum lipase. Now what do you think is the condition here? Now this particular feature, epigastric pain radiating backwards, this is classical for acute pancreatitis. So this particular statement is very indicative of acute pancreatitis, and this is strengthened by this particular concept that serum lipase is also high. So this is also supporting this diagnosis. So it means the lady is having acute pancreatitis. Now let us discuss the etiology of acute pancreatitis. So number one is gallstones, right? Number two is alcohol. So considering a lady, most likely it is going to be gallstones. Clear? So this is how you have to reach up to the etiology, but before that you need to make the clinical diagnosis, then only you can reach up to the, you can think of etiology, right? So clinical diagnosis is acute pancreatitis, and fatty, 40, female, these are the risk factors for gallstones, right? So a female in 40s, fatty, female, fertile, flatulent, all goes as a risk factors for gallstones. So that's why in this particular question the answer will be gallstones. Okay, this is all you should remember. Then next question, a woman with recurrent biliary colic, again and again she is having colicky pain, undergoes laparoscopic cholecystectomy. So the surgeon has taken the patient for laparoscopic cholecystectomy, but during dissection Callet's triangle is essential. Now, which structure forms the boundary of Callet's triangle? So, it's a straight anatomical question woven along with some clinical words. So, a lady who is having recurrent biliary colic. So, if we take this keyword here, recurrent biliary colic. Recurrent means again and again. Biliary colic. So again, this is an indicator of gallstones. Clear? So this is an indicator of gallstones, and therefore the attending surgeon planned to remove the gallbladder. So he planned for laparoscopic cholecystectomy. Now the question is actually they are just asking you the basic anatomical fact. So what you need to know about the Callet's triangle. So here you have to understand that what are the boundaries of Callet's triangle. Upside is one artery, then medially hepatic duct, and medially is the cystic duct. Clear? So this is the cystic duct, which is laterally coming from the gallbladder. Now here we have the left, and this is the like this. So this is the common hepatic duct, this is the right hepatic duct, this is the left hepatic duct, and together they will form the common bile duct. So this is the common bile duct. Now this is the Callet's triangle, and superiorly this is the cystic artery, right? So this is the cystic artery. Clear? So medially common hepatic duct, this is medial. Laterally cystic duct, okay, this is laterally, and superiorly is the cystic artery, and this one is the Callet triangle. Clear? So this is just basic concept which they try to ask you. So the medial boundary of the Callet's triangle is formed by common hepatic duct, okay, and common hepatic duct, it is formed by the joining of the right hepatic duct and the left hepatic duct. So next question, a patient develops progressive painless jaundice, then palpable gallbladder and weight loss, most likely diagnosis. Now again we can write the keywords. So here one term is progressive. It means the problem is priya ready, very good, priya ready, very good. So when we say progressive, it means the condition is increasing day by day, right? The condition is increasing day by day. Then second is painless, there is no pain or no inflammatory process. Then third is jaundice, it means the bilirubin is increasing in the body, right? So the bilirubin level is increasing in the body. Let me write the full form. Then palpable gallbladder. Now this is also one very important keyword, palpable gallbladder. It means the bile is accumulating within the gallbladder. So we can write here bile is accumulating, and it suggests that there is some blockage in around CBD, so that the bile is not going into the second part of the duodenum through the major duodenal papilla. And lastly, there is one more important keyword, weight loss. And I told you, the moment you find the word weight loss, especially progressive, always think of some malignancy. So it means there is some tumor. Weight loss, always indicator of malignancy. Progressive means tumor will increase day by day. So this condition is, or the tumorous mass is increasing day by day. Now the question is, what is the location of this tumor? So now here you need to remember two important things. So one thing is very important, we are thinking of some malignancy here. So what we need to remember here, there is one Courvoisier's law, right? So there is Courvoisier's law, and if a patient is having obstructive jaundice, now there is blockage, so obviously this is which type of jaundice? Obstructive jaundice, or you can say conjugated hyperbilirubinemia. So we need to rule out like what is the site of obstruction. Now here the important keyword is palpable gallbladder. So this law states that whenever you find palpable gallbladder, it means it is not a case of cholelithiasis or cholelithiasis. In fact, it is periampullary carcinoma, right? So Courvoisier's law states that if a patient presents with obstructive jaundice and we are suspecting a malignancy, then this is most likely to be periampullary carcinoma if the gallbladder is palpable, right? So here now periampullary means the region is somewhere around the ampulla of Vater where the common bile duct opens, and in that region what we have? Carcinoma head of pancreas, it can be the second part of duodenum itself. So commonly it is the carcinoma head of pancreas. So very good, Priya, absolutely right, carcinoma head of pancreas. Now remember why this is not gallstones related carcinoma, gallbladder carcinoma, because what will happen in gallstones, there is recurrent inflammation, and because of this there will be stricture of gallbladder. So the gallbladder will never be palpable, right? So the gallbladder is non-palpable, right? So it is non-palpable. So the only difference in terms of malignancy presenting with obstructive jaundice, you have to check the word whether the gallbladder is palpable or the gallbladder is not palpable. If the gallbladder is palpable, straight away go for periampullary carcinoma, especially carcinoma head of pancreas. If the gallbladder is not palpable, it indicates that because of repetitive inflammatory episodes, the size of the gallbladder has shrunken and therefore it is not palpable anymore. So the moment you have a palpable gallbladder, this is the keyword here, palpable gallbladder, go for periampullary carcinoma, classically carcinoma head of pancreas. Okay, next question. A 70-year-old man has a reducible groin swelling. Okay, so reducible groin swelling that protrudes medial to the inferior epigastric vessels. Now what is your diagnosis? Now here let us take the keywords. The very first important word which has been given to you is 70-year-old male. So it means it is an elderly. Okay. Then another word is reducible, means the swelling increases in size and the patient can press upon the swelling and it will go back inside the abdomen, right? So it means the swelling is reducible. So suppose if the swelling is like this, the moment the patient presses by the hand, the swelling will go inside and it will become something like this. So the swelling has gone inside, right? So this means this is reducible. It can be reduced. Now what is more important here? Anatomical clue has been given, medial to inferior epigastric vessels. Now here you should know the Priya. Okay, let me give you the concept first. Now it is given medial to inferior epigastric vessels. Now here you have to think of a anatomical triangle in which one of the boundary is formed by inferior epigastric vessel. So let me give you that clue. So suppose if this is the inferior epigastric artery, this is the inferior epigastric vein, like this, okay. Then here there is a muscle, right? So there is a muscle in the and lower down there is one ligament like this. So this ligament is inguinal ligament. This muscle is rectus abdominis, and these are obviously inferior epigastric vessels. So now what is this triangle? This triangle is known as Hasselbalch's triangle, right? So what is this Hasselbalch triangle? So medial, so these inferior epigastric vessels, they form the lateral boundary of Hasselbalch's triangle. Clear? So these vessels, they are forming the lateral boundary of this triangle. So this one is medial, right? So this one is medial boundary, this one is inferior boundary, and this one is lateral boundary. So now the question says that the herniated mass is coming like this. So this type of hernia is known as direct inguinal hernia. So this is direct inguinal hernia, and one very important clue, that direct hernia is seen in elderly people. Okay, direct is seen in elderly, indirectly inguinal hernia is seen in children. So the moment you have any description of elderly, presume that okay, the question will be taking me towards direct inguinal, right? So this is direct inguinal hernia. So the direct inguinal hernia, and here the herniated mass enters through posterior wall of inguinal canal. Okay, it is entering through the posterior wall of inguinal canal, and then it is coming out through the superficial inguinal ring. Okay, so it is not entering through the deep inguinal ring, but it is coming out through the superficial inguinal ring. So that's the classical. Yes, Priya, yes, Himalaya, both of you are right, absolutely right, bacho. So this is a classical presentation of direct inguinal hernia. Clear? Please don't do any sort of mistake in this. This is a very important topic, inguinal hernia, and very important to score in this type of easy lollipop questions. Chalo, next question. Elderly woman presents with painful, irreducible swelling which is below and lateral to pubic tubercle. Now this is also one more important question, right? So let us take the keywords first. So one of the important keyword is elderly woman. Now this is very important, woman. Now what is happening? Painful, irreducible swelling. Okay, so irreducible swelling. And what is the location? If suppose this is the inguinal ligament, this is the pubic tubercle, right? And somewhere this is the, you can say, the thigh part. So the swelling is somewhere here, right? So swelling is below and lateral. So it's come like this. So below and lateral to the pubic tubercle. So this is of course the pubic tubercle. Now here, what can be the answer? Very good, Priya, very good. Now there are certain keywords, very good, Himalaya. There are certain keywords, and that will make sure that you are choosing the right answer. The number one is women, females. Number two is painful, and number 3 is irreducible. These are the classical points going in favor of femoral hernia, right? And if you know the anatomy of the femoral canal, especially from the medialmost compartment, there is herniation. So, and since that area is very small, so once there is herniation, it is not easily reducible, right? So that's why, since that area is very small, it cannot be reduced. If there is pain, it means it is getting strangulated. So that's why femoral hernia is very problematic in clinical practice, right? And how clinically we differentiate? Below and lateral is femoral, and above and medial is inguinal. So this is inguinal and this is femoral, right? So the pubic tubercle is helping us to clinically have an impression whether the given hernia is a case of inguinal hernia or femoral hernia. So if the sac is above and medial, that is inguinal hernia, and if it is below and lateral, it is femoral hernia, right? So yes, Himalaya, absolutely right. Below and lateral pubic tubercle, super bache, super. So, and remember one more thing, femoral hernia is most common in females. That is also one statement which you should know. But at the same time, you should know one more statement. But the most common hernia in females is inguinal. Is that clear? Femoral hernia is commoner in females, but most common type of hernia in females is indirect inguinal, right? So that, just make it clear. Yes, absolutely right. This is indirect inguinal. Okay. Yes, absolutely right. Priya, बच्चे बहुत अच्छा, very good, right? So this is also, and therefore, whenever you find this word woman in the hernia case, always presume that okay, the question statement might take me towards the diagnosis of femoral hernia. Okay, so see, such a beautiful concept and very easy to score. There should be no mistakes in such questions. You need a little bit of stable mind. You will definitely make it, I am very sure. Okay, next question. A patient has dilated tortuous veins along the medial aspect of the leg, and then the Trendelenburg test is positive after releasing the proximal tunicate. Now, where is the incompetence? Now, obviously, I think if we go with the keywords, dilated tortuous veins, I think the moment you get this much of word, you can easily say that this is a case of varicose veins. And we know that what is the pathology in varicose veins? The valves are incompetent. Now here you have to answer what is the site of incompetency of that valve. Now usually, suppose if the question is only this much, I would have said that okay, there is incompetent valve in the superficial veins of the body. But here, especially one word has been given, and that is the Trendelenburg test. Trendelenburg test. Now, this is different from the Trendelenburg test, what we do in orthopedics, where we check the abductor mechanism. This is different. Now, what we do here, firstly, we will tell the patient to lie down on the couch. Then, so supine position. Then we will lift the affected lower limb, right? So we will lift the affected lower limb and we will try to exsanguinate the blood from the saphenous vein into the femoral vein, because we know that the great saphenous vein, it drains into the femoral vein. So what we are doing here, we are trying to push all venous blood from great saphenous vein into femoral vein. Okay, so we are doing this. Now, once this is done, what we will do? We will apply a tourniquet at saphenofemoral junction, right? So, saphenofemoral junction, and then we will tell the patient to stand. Now, we will release the tourniquet and we will look for varicosity, right? If the varicosity is absent in the lower limb, right, somewhere around the leg region, it means the saphenofemoral junction valves are okay, because they are not allowing the blood to flow back from the femoral vein into the great saphenous vein. But if the varicosity reappears, it means the saphenofemoral junction valves are incompetent. They are not controlling the leakage of blood back from the femoral vein into the great saphenous vein. So, this is the Brody-Trendelenburg test, which is done to check for saphenofemoral valve competency. Because normally, as soon as we release the tourniquet, the varicosity should not come, because the valves are okay, they will not allow the blood to go back into the great saphenous vein. So, this is a clinical test, right? So, this is how you need to answer this. But I think now onward you should not do any mistake in this, but this is how you have to reach up to your answer. Okay, chalo, next question. A patient has a shallow ulcer with irregular margins over the medial malleolus and there is pigmentation. Now, which type of ulcer is this? So, here if we go for the keywords, the classical, there are two keywords. One is the site, that is medial malleolus, and the second important is pigmentation. Clear? So, there is ulcer over the medial malleolus area with irregular margins, it's shallow, and there is surrounding, very good Priya, there is pigmentation of the surrounding skin, and this is classical for venous ulcer, right? So, this is classical for venous ulcer. Now, for arterial ulcer, there is a classical keyword that pulsations will be absent, right? So, here in venous ulcer, distal pulsations are present. So, this is one way of differentiating arterial ulcer from venous ulcer. Palpate for the pulsations. If it is present, it means it is going more into favor of venous. In arterial ulcers, the pulsations of the nearby area are absent. So, that's how we differentiate the two. And the diabetic and the neuropathic, they are trophic ulcers, especially over the pressure points. Leave that. A chronic smoker presents with intermittent claudication, and then it is progressing to rest pain and finally toe gangrene. Now, see, distal pulses are absent. So, I think it's one of the most easiest question you can ever have. So, let's write the keywords. Now, here one of the important keyword is chronic smoker, then intermittent claudication. I think yes, very good Priya. So, intermittent claudication means like pain comes on activity and relieves on rest. So, this is known as intermittent claudication. Clear? Now, as the arterial obstruction will keep on increasing in over a period of time, intermittent claudication will progress to rest pain. It means the patient will have pain during all the time of the day, even at rest, and then finally when there is significant disruption of the arterial blood flow, gangrene will ensue. So, this is the classical description of Berger's disease, and obviously the distal pulses are absent. It means the there is obstruction, right? So distal pulse is absent. So this is a classical thromboangiitis obliterans or Berger disease. Very good, Priya. Then next question, RTA victim arrives unconscious. Pulse 130 per minute, BP 80/50. First step, what you will do at the earliest? Now this is a very beautiful question, right? So if we write the keywords, unconscious patient, BP low, heart rate high. Now what you will do? Priya, very good, very good. See, in an unconscious patient, the very first is airway, because the patient himself is not able to keep his airway patent. So because the patient is unconscious, so we have to take care of airway. So even though the vitals are deranged, but firstly we should focus on airway. And most likely in this case, since it is a RTA, it's a RTA victim, so there might be possibility of cervical spine injury. So we have to stabilize the cervical spine also. So unconscious patient cannot take control of the airway by himself, so we have to take care. And RTA victim, possibility of cervical injury, so stabilize it. So therefore, the very first thing in an unconscious patient, what you need to do is airway management, followed by cervical spine protection, and then you can go for breathing or circulation, anything later on, right? But firstly, priority should be given to airway and stabilization of the cervical spine. Now, a hypotensive trauma patient, fast scan is done. I think all of you must be knowing about fast scan, that is focused assessment by sonography in trauma, right? So in a trauma case, we are doing ultrasound and we are doing a focused assessment. Now what we are actually trying to detect by doing ultrasonography in a trauma patient? Now the patient is hypotensive. Clear? So the patient is hypotensive. It means there is possibility of some internal bleeding. So there is some internal bleeding. Very good, Priya, and very good, Dheeraj. Absolutely right. So there is some internal bleeding. So this internal bleeding is interpreted as free fluid, right? So in terms of fast, we use the word free fluid, and that that is synonymous with the internal bleeding. So blood or free fluid, that's the same thing, right? So don't get into that word trap. Free fluid, internal blood, it means the same, right? So we will look for in fast, we will look for hepatorenal recess, splenorenal recess, pouch of Douglas, pericardium, like that. Okay, so here the blood or free fluid, that's the same word. So we are looking for free fluid. Very good, Dheeraj. Very good, Priya. Now next case, a young man sustains temporal bone fracture. He loses consciousness briefly, then regains it, and then again deteriorates. Most likely diagnosis. So if we go with the keywords, very important is temporal bone fracture. Then what do you see? A classical unconscious, then conscious, then again unconscious. Yes, I think very good, Dheeraj. Very good, Priya. So this is the classical description of lucid interval, right? So this is the classical description of lucid interval, where the patient is initially unconscious, then he will gain consciousness for a certain period of time, but finally again he will pass into unconscious state. So that's the classical description of lucid interval. And temporal bone fracture, especially the examiner is pointing towards pterion, and we know that pterion, H-shaped junctional area of 4 cranial bones, and this is related to which artery? Middle meningeal artery. Clear? So this is middle meningeal artery. And when there is rupture of middle meningeal artery, which type of hemorrhage will occur? Very good, Dheeraj. So this is extradural hemorrhage or epidural hemorrhage, right? So this is the same thing. So very beautiful question, and I think most of you must agree that there is no exam which doesn't, Sumit, very good Sumit. So there is no exam which doesn't include a question from either extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, or diffuse axonal injury. So neurosurgery, every time you will have a question. That's for sure. So make sure you don't fall into the trap. Your concept should be crystal clear, and this is worth scoring. There is no scope of any doing any mistake in this kind of question, right? So students, this is enough for this session, and I'm very sure you must have enjoyed the session. Very shortly I'll come up with another subject. Thanks for joining. God bless. Keep on studying. Goodbye.